And I know, Danny, because I've spoken to some of the pharmacists in Canada about efforts in Canada to be proactive in actually calling patients at home before they come in to see the doctor, managing and expecting the side effects. Can you talk a little bit about kind of that interface between the healthcare system and the patient vis-a-vis oral medication to proactively deal with things before they become problematic?
We definitely try to play a proactive role. So in Alberta and Canada, for example, our pharmacists will have an outpatient drug program where they actually call the patient at 1 week to see if they have any side effects and to manage them over the phone. And if there are any difficulties, they call us. Similarly, we have nurse practitioners that help with their side effect profiles as well. So it's not just about physicians, it's definitely about the team and getting them involved very early.
Brian?
No, I was just going to say, I think that's really incredible that the pharmacist. I'm wondering how that sort of system developed, where the pharmacist calls. I mean, I don't think we're quite as proactive, certainly in this.
And I actually think that this is more of an editorial comment. When I heard about the processes that are taking place in Canada, I was struck by the fact that since so many of our patients in oncology are more and more orally delivered therapy, these are practices that have been around in the non-oncology practice for some time, but now we're starting to see that eke out into our oncology practice. So let's close this section. Just talk a little bit about algorithms for care. We have guidelines like the NCCN guidelines. Many of our institutions are developing algorithms for how we think patients should be managed. Chuck, anything other than the existing guidelines that are out there that your institution and you are using in choosing frontline therapy?
We have some very crude algorithms. Personally, I think NCCN is way too broad. It gives wide open carte blanche, almost whatever you want to do, supported by data. Based on the data we have, we tend to use pazopanib or sunitinib first line, and then for second line, it depends on clinical circumstances, how long they've responded, what the nature of the response was. Generally, if they've had stable disease or response with, say, 8 to 12 months on a first-line TKI and progress, we'll go to a second-line TKI, usually axitinib. My own personal bias is that VEGF probably is the main driver pathway of most of these cancers. If they blow right through the first-line TKI in 4 to 6 months, I'll often then use everolimus as a second-line drug.
So Brian at the Cleveland Clinic, and then Danny in Calgary, how are you starting to integrate, the conversation about value, which is basically the cost and outcome algorithm? And are you starting to think about, not just in kidney cancer, obviously, but more broadly, how do you pick the agent? How is the person able to afford the agent? These are very expensive drugs. Do you have a conversation with your patient when you sit down with them that, do they meet your financial counselors and talk about that? How's that integrated at the Cleveland Clinic?
Yeah, so our preference is similarly for oral agents up front. So I'll have a conversation with the patient about co-pays, telling them that, gee, for some people it can be very easy and cheap, and for other people it's prohibitively expensive and everywhere in between. And as mentioned, it often takes a week or two to sort that out, which can be sort of agonizing for the newly diagnosed patient who wants to start that day. They come to your office thinking you're going to treat them that day. We're also thinking, as everybody is, about care paths, how we care for patients and how often do we really need scans, and do I need full thyroid function tests every time I see the patient, and just all those little things we do based on habit, not science. So we're starting to get granular around that, in all the diseases, but kidney cancer included.
And Danny, give us I know you practice in Calgary, but give us the Canadian view of healthcare delivery in a setting of oral medication, how they think about it, how it influences your decisions.
Well, as we know, these drugs are very expensive, but they have very good value in terms of doubling patients' overall survival. And so in Canada, we don't have discussions about copay because they are paid for all patients and all all citizens of Canada, and we can get the drug the same day, but we definitely have care paths. So for example, we want our physicians to follow very carefully crafted guidelines. We usually use sunitinib up front. Pazopanib has been added in to be on equal footing as sunitinib, but to be honest, I think there's still a lot, sunitinib still is the dominating first-line therapy in Canada. I think a lot of us are now trying to maximize patients' time on targeted therapy by managing their side effects, but also changing doses as well and dose schedules. So for example, if someone doesn't tolerate 50 milligrams of sunitinib 4 weeks on, 2 weeks off right away, it doesn't mean an automatic dose reduction or an automatic switch to therapy. Perhaps you can get away with 50 milligrams 2 weeks on, 1 week off for a little bit. There's actually a clinical trial ongoing with George Bjornison that looks at the dose individualization of sunitinib, where if patients aren't having any side effects at all, we could dose escalate. And so that's in the clinical trial setting only, of course. And if patients do have side effects, we try to manage the dose reductions very carefully and not bring them down to 37.5 right away, but play around with the schedule a little bit. And so I think we're seeing some very encouraging results, and we're actually, by dose individualization, we're actually seeing better progression-free survivals and overall survivals than historic controls, which might outdate some of the trials that we have now and some of the benchmarks that we have now.
So